session will also be very interesting and I hope also very interactive. The title is what the science is saying. It's right there, making the case for treat all or to treat all. And we will have 2 presenters today, right? 2 presenters or one?
I don't know. There is
One
Mrs.
presenter.
Springer, you're one?
It's not the same.
Okay.
Okay. But in case there are questions, because you know what happened last week, we had 3 persons who had to answer question, although only one gave a presentation, so you never know, right? So Dr. SIngh-Anthony, she is the coordinator within PANCAP, knowledge coordination. Yes, knowledge coordinator. That says a lot. Knowledge coordinator within the context of PANCAP HIV/AIDS. Very good. So I think everybody knows Dr. Singh. No? Really? Oh. Well, then I'm going to ask Mr. Springer to introduce Dr. Singh, because I don't want to take the chance to give an introduction and to leave anything out. So Dr. Springer, you introduce Dr. Singh, please, and then we'll give the floor to Dr. Singh. Thank you.
Thank you very much, DSG, and I have the pleasure of introducing Dr. Singh, who I have known for the last 23 years. We worked together at Georgetown Public Hospital, and Dr. Singh was at that time one of the few physicians who you could call upon to support you in the delivery of care to people who are living with HIV and AIDS. She eventually became the director of the Genitourinary Medicine Clinic, which was referred to sometimes in those days as the AIDS Clinic or the STI Clinic. It is now called the National Care and Treatment Center. And then she was elevated to National AIDS Program Coordinator within the Ministry of Health in Guyana. Dr. Singh is a medical doctor, having studied in Russia, and she speaks Russian fluently. And in addition to that, Dr. Singh holds a Master of Public Health degree from the St. George's University in Grenada, and she has, of course, over 24 years of experience as a medical doctor, but dedicated at least 15 of those years to HIV and AIDS. So she brings with us tremendous experience and also a passion for working in the HIV/AIDS arena. She is now the knowledge coordinator within the PANCAP coordinating unit and performing those duties on behalf of the Johns Hopkins University with support from USAID PEPFAR. So I now hand you over to Dr. Shanti SIngh-Anthony.
Yeah.
Thank you. That was good, right?
Yes.
That was very good. Thank you so much, Derek. Thank you, DSG. The last presentation that we had from Dr. Green, he mentioned a challenge in the region of us not really having good access to strategic information. And one of the things that we do at the PCU is we conduct evaluation of all of our activities. And so to start off today's presentation on what the science is saying and making the case for a treat-all, we've put together a really quick pre- and post-test evaluation for you. And so the way we do this at the PCU is we do this online. So if you log into, that's the website, if you can pull up your smartphones, I know we all have smartphones. If we can pull up our smartphones, you have 3 questions. It should take us no more than a minute and a half to answer the questions.
Is that a bell signaling to start?
So we can actually monitor if you're responding. Yeah. Anyone has accessed the survey as yet? Yeah. Okay.
Yeah. Let's start this with it. You should be seeing that on your screen.
You put it there so they can see. You can, that's okay. Oh, that's fine.
One question?
There are three questions.
Three. Gender and then an actual yeah. Then we'll do a post. So it's very simple.
Very simple. We have 8 persons responding so far. Yeah.
Turn the screen and show them so they can see that the responses are coming up. Because usually when we have the email addresses for everybody, we would just send out the survey beforehand, so people then begin to complete. Have to put the lights on, Shanti.
I think so, yeah.
Yeah.
Could somebody please dim the light?
The lights by the screen. Yeah.
So you can see from the slide that the majority of us fall within the age group of 25 to 55. That's the results coming up live. We have 18% of us older than 55. Most of us are women in the room.
With phones as well.
Very interesting. Right. Yes, yes, yes.
Yeah, tell them walk with the phones. Yeah.
I'm happy that 78% of us strongly agree that we can end AIDS.
Excellent. Yeah.
Good job. So I think we're good.
Can
yes.
can you also say what percentage of the women or the male are saying that we can end the AIDS by that by 2030?
Not on the live result, but we
But
can
he can
cross-tabulate later. Yes.
yeah,
That
Yeah.
would be interesting.
Yeah.
Yeah.
So.
Yeah, that would be interesting.
All right, so for the actual presentation, here is what I'll go through really very quickly. The history of HIV and some fundamentals of antiretroviral therapy, because we're talking about making a case for antiretroviral therapy and treat all. Looking at ARVs in the role of prevention, and not just necessarily speaking of making the case for treat all, but you can actually use treatment, antiretroviral therapy, to prevent infection. So on that note, I'll mention very briefly some of those cases. So pre-exposure prophylaxis, post-exposure prophylaxis, and some other biomedical prevention. And I thought, based on the last presentation from Dr. Green, that I'll throw in a slide or two on condom use and voluntary male circumcision, so we can have that discussion. Armed with all of these tools, how do we really make the case of ending AIDS and using 90-90-90? So that's the outline of the presentation. In terms of the history of HIV and ARVs, I think it's no news that in 1981, 5 cases of pneumonia was reported in gay men. But by the end of 1981, we saw that cumulatively you had about 270 cases of severe immune deficiency. At that time, that's what it was called. And of those, you had 121 persons who died. So death came quickly once immune deficiency was diagnosed. Very quickly in 1983, 2 years later, the HIV virus was discovered. And I don't know how many of you had the chance to look at a movie that's called And the Band Plays On, or The Band Played On. It's a beautiful movie that speaks to how the HIV virus was discovered, and if you haven't had a chance, I would encourage that you look at that movie. So the virus was diagnosed in 1983, was Tom Hanks. Yeah. Right. In 1985, the first test became available, so we could have made a diagnosis of HIV. And then the big one happened in 1987 when the first antiretroviral came out, which is AZT. And then in 1995, we then moved to providing combination antiretroviral therapy, or what became known as the cocktail then in 1995. So quickly to put the ARV discussion into context, here is what the HIV virus looks like, and it's an RNA virus to begin with. But if you can keep 4 things in mind. First, that within the center of the virus, within its genetic material, there is what's called a protease. There's something called a reverse transcriptase, and then there's the integrase. Now, those are enzymes that allow the HIV virus or facilitate the replication of the HIV virus. And then the 4th thing is what's called a glucoprotein GP1 to enter the docking glucoprotein. So what really happens is that in the HIV cycle, there are 7 stages or 7 steps. The first step is where you have that GP120 would actually dock onto the CD4 cell. So this big cell that you see here is the CD4 cell. Once the docking takes place, then it merges itself into the CD4 cell, which is what happens here, and it empties its genetic material into the human CD4 cells. It infects the human CD4 cell. To help this process, the 3 enzymes that I alluded to earlier, which is the integrase, the protease, and the reverse transcriptase, those help the HIV virus to replicate itself. It replicates and it buds out of the CD4 cell, providing many HIV cells, additional HIV cells. And so it may seem like it's very simple, but in fact, if you think about it, there are several points within which the HIV virus interacts with the CD4 cell. So this is 1 point here, 2 point, 3 point, 4 point, 5 point, 6 point, many different points. And because of that specific reason, there are several classes of antiretroviral therapy. In fact, there are 6 different classes right now, and that's one of the main challenges in terms of coming up with a vaccine for HIV because of how complex the HIV cycle is. So in terms of making the case for a treat-all and really looking at ending AIDS through prevention initiatives, I wanted to use this framework here to take us through the presentation. And the first thing I'll talk about is those who are infected, how can HIV virus or how can antiretroviral therapy help to 1, keep those people alive, and 2, to contribute to prevention in terms of preventing infections from happening. So in that first case, I want to ask a question now. DSG said that we should keep it as interactive and participatory as possible. What is your take on what treat-all is? Anyone? Not the PCU, Derek said. Yeah. Or the PR.
I get a sense that it is not dependent on means. That it should be, the drug should be available to all once effective. That's my sense. Am I correct?
Thank you. Yes, you're correct. Do we have any giveaways, DSG?
Let's continue.
Okay. Right, so here is what treat-all is, and this is according to the World Health Organization. It is initiating antiretroviral therapy among all adults living with HIV, regardless of what their CD4 count is. And this is a new concept, relatively new. In fact, WHO introduced this in June of 2016. But prior to 2016, persons were treated based on their CD4 count. And so in the very early days of the epidemic, there was no treatment. Once treatment became available, then persons were initiated based on their CD4 count of 200 or less. That then moved later on to a CD4 count of less than 350, and what WHO is saying right now is that anybody, irrespective of their CD4 count, should be placed on treatment. Why is this so, and why treat all? Because there's evidence to show that treating persons as soon as you find out their HIV status reduces mortality, so let's be less people get sick, and then importantly in the context of ending AIDS and treatment as prevention, it reduces HIV transmission. And so without antiretroviral therapy, what you see on the side here would have been a normal progression of the HIV virus. So someone would have gotten infected, their CD4 would have climbed very shortly after infection, but then would begin a gradual decline of CD4, and with the decline there are a number of opportunistic infections that one would have acquired with the decline in CD4 test. And eventually with opportunistic infection that would lead to AIDS-related death after a few years. That entire course or disease progression has now changed with access to antiretroviral therapy. So how do we know this, and where did the science come from? There are three main trials that has led to this decision. There's the START trial, there's the Temprano trial, and there's the HIV Prevention Trial Network 052. So the START trial really looked at persons who were HIV positive but not on treatment, and who had CD4 greater than 500. You would recall that I just said that persons were being started on treatment if they had a certain CD4 level. At this time when the STAR trial was in place, CD4 of 500 was not the threshold for starting persons on treatment. And so what the trial did, it got together 4,685 persons, randomized them into two groups. The first group was the group who received treatment immediately, and the second group was the group in which treatment was deferred. The trial had some interim analysis that came out in May 2018, and in fact this trial started in 2005. The interim results that came out in 2018 showed that there was good outcome. Sorry, 2011, sorry. What the results showed was that for the deferred arm of ARVs, that you had higher death rates for the deferred arm when you compare that to the immediate arm. And so if you look at some of the endpoints of the study, within the immediate arm, and you compare that with the deferred arm, serious AIDS-related events, you had 14 that happened in the immediate arm where persons were on ARVs compared to 50 in the group that had no ARVs. Similarly, when you look at death, 12 persons died in the immediate arm, 21 persons died in the deferred arm. And you can see some of the parameters. You look at cancer, 3 persons in the ART arm had cancer compared to 10 persons in the deferred arm. And so all of the endpoints for the two groups, it was very clear that the persons who received treatment earlier had better outcomes. What this slide shows is a breakdown of the different types of cancer in the immediate versus the deferred arm. So that was one bit of evidence. Yes?
Just out of curiosity, how did the cancer group got into the AIDS group now? Or those are the AIDS people with cancer and so on? Go back to the previous slide.
Right.
Okay, I see the cancer and the AIDS. How did, what is the cancer result, right? Yeah.
Right. And so,
right, if the cancer came
because yes,
Oh,
yes.
okay.
So it was directly related. Yeah.
Oh, okay.
Oh, so wait a minute.
Yes.
HIV causes cancer.
Cancer. Yes.
Okay.
Yes.
Right. So the second piece of study came from another study called the Temprano study that was conducted in Ivory Coast in Africa. This was a different study, and it was a 2x2 factorial study. So there were 4 things that were measured. So it measured persons who were immediately placed on ART or ARVs, persons who were immediately placed on ARVs but also had prophylaxis for TB. In those countries you have high burden of TB. And then you had a deferred arm that had persons who were deferred on ARVs, but persons who were deferred on ARVs plus did not receive treatment for TB. What that study showed too is that at the end of 30 months, your probability of dying if you're in the deferred ART group was 14.1%. So if you did not receive ARVs, your probability at the end of 30 months was 14.1% of dying, compared to if you received ART and you also received prevention treatment for TB, and that was 5.7%. And so again, this was another piece of evidence that was used to show, yes?
Was the similar analysis done for the Caribbean region, or you're just using because of studies?
These are some of the really very large randomized trials that were done globally that assisted WHO to make some of the recommendations that came out in the guidelines. Yeah. And then finally, there was the HIV Prevention Trial Network 052 study. This was started in 2005. It was done in 9 countries, and there were 13 large sites in 9 countries. What this study did, it looked at people who are in serodiscordant relationships, and by that I mean one partner was HIV positive and the other partner is HIV negative. And so what the study did, it looked at whether or not if you put someone on treatment, whether the partner is protected. And so in the early arm, persons were placed on treatment. The partner who is HIV positive was placed on treatment. In the delayed arm, the partner who was HIV positive was not placed on treatment. At the end of May 2011, this particular study also released some interim findings. And in fact, the findings were so compelling that the researchers asked the participants whether they wanted to continue in the delayed arm or whether or not they'd like to be placed on treatment to protect the partner. In any event, the study continued until May 2011, and the reason why the study continued until May 2011, because at the end of, until May 2015, at the end of May 2011, what it did show is that there was 96% reduction of HIV transmission within couples who were assigned to the early arm, compared to what happened in the delayed arm. And so, in terms of continuing the study until May 2015, the researchers wanted to find out whether this 96% was durable and whether 96% will continue beyond to May 2011. What they did find is that this continued, and in fact, it continued. It was a little bit lower, but it still maintained at a high 90%. So 93%, there was a risk reduction of 93% among the persons starting ARV. Now, one of the important parameters is that what the study looked at very clearly to see if there was transmission in either one of these groups, whether it was linked transmission. And by that, what we mean is that if the partner acquired HIV in the process, was it from the partner who's HIV positive, or this infection come from somewhere else? And what they find is the majority of infections that came from the delayed arm were actually linked infections of the original source partner who's HIV positive, but not on antiretroviral therapy. And so you can see from April 2005 to May 2015, you had 19 new infections, among the persons who started ARVs, but you had 59 new infections among the partners who did not start ARVs. 43 of those infections were linked in the delay arm, and three of those infections were linked in the early arm. And so those are really the 3 main pieces of evidence that contributed to WHO guidelines, and this is one of them. In April 2012, coming out from the HIV Prevention Trial Network 052, when the interim results were released in May 2011, WHO brought out this guidance to say that as clinical practitioners, we should offer antiretroviral therapy to persons with CD4 greater than 500 once they're in a serodiscordant relationship. So if the partner is negative, that person should be offered ARVs. At that time in 2012, it says greater than 350, and the reason for that is that in 2012, that was the WHO guideline. So persons should be initiated on treatment if their CD4 is less than 350. The guidance came out to say if you're in serodiscordant relationship and your CD4 is greater than 350, you should be placed on antiretroviral therapy. So there were specific provisions made for serodiscordant couples. Taking all of that into consideration, in June 2016, WHO brought out its revised guidelines. What's important, some of the new guidance, and I think overarching to all of the guidance, is that ART should be started in all adults living with HIV, regardless of their WHO clinical stage or at any CD4 cell, and that's why we've established what Treat All is. And so this guidance came out from WHO in June of 2016. So I think in terms of making the case for Treat All, we've established that it reduces mortality and it improves survivability. It reduces morbidity and it also reduces HIV transmission, like we've seen from the HIV Prevention Trial Network, O52, among serodiscordant couples. So in terms of PrEP now, so that's about Treat All. For PrEP, which is pre-exposure prophylaxis, WHO has also brought out guidance in this same June 2016 guideline, and they've taken into consideration 12 PrEP studies. So there are a number of studies that have done, but this is the recommendation that WHO has come out with, that oral pre-exposure prophylaxis containing TDF should be offered as an additional prevention choice for people of substantial risk for HIV infection as part of combination prevention. So even if you're not HIV positive, you're HIV negative, but you're at risk for HIV, then you can be offered antiretroviral therapy as prophylaxis, and that's what PrEP is. And we'll talk about who is at risk and how do we establish who is at risk. And so I think the slides got a little bit mixed up. So where did this evidence come from? There are a number of studies. The PROUD study was conducted in England. And what the PROUD study did is they enrolled 554 persons, and these were primarily men who have sex with men and persons from the community of transgender population, primarily the trans women population. And again, what they had two arms. You had an arm of 276 persons, which was the immediate arm that received treatment, and you had an arm of 269 persons who did not receive treatment. And so remember, these are HIV negative persons, and so what the study tried to establish is whether there will be seroconversion. So any person within the study, did anybody become HIV positive during the study? So overall, there were 22 infections that happened among the 400 plus persons. But in the immediate arm where there was antiretrovirals given to the person, you had 3 infections or 3 seroconversion taking place. And among the deferred arm, you had 19 infections taking place. So they did not receive ARVs, and you had a larger percent. What that incident turns out to be is 4.9 per 100,000 patient years for overall infection. But among the immediate arm person receiving ARVs, that was 1.3 new infections per 100,000 patient year and 8.9 new infections in the deferred arm. There's another study that contributed to the guidelines, another piece of evidence that's called the Hypergay study that was conducted in France. And what this study looked at is what's called a on-demand PrEP. So this previous study, the PROUD study, and many of the other studies that are available, speaks to somebody who is at high risk receiving a single pill every day. What the Hypergay study speaks to is to on-demand PrEP, and what that means is that the person anticipates that he or she will be engaged in unprotected high-risk sex. That person takes 2 pills before sex. The person will take 1 pill 24 hours later, and then the person takes another pill 48 hours later. So that's another form of PrEP that has been studied. And so the results also has been really good. And so you can see the probability of HIV infection in the group that did not take the on-demand PrEP. You can see that the probability of HIV infection was close to about 9%. And then you can see from the group that had the on-demand PrEP that the probability of HIV infection was really very low. And here you can actually see some real results. So in terms of HIV incidence, you had a 9 per 100,000 patient year in the group who had no on-demand PrEP treatment, compared to 1.2 per patient, 100 patient year among the group who actually had on-demand PrEP. So who is eligible? And I know the question has come up. So who do you give PrEP to? And WHO has outlined the indication for PrEP. So to begin with, if someone requires PrEP or someone shows up asking for PrEP, the first thing is that person has to be HIV negative. So you cannot be HIV positive and be asking for PrEP. You have to have had a sexual partner with HIV who has not been infected, who has not been on effective therapy. So this is somebody who has a partner who is HIV positive but has not been on treatment, and so more than likely that person is very infectious. Somebody who is sexually active in a high HIV prevalence population, and we've talked about some of those. It would be the population of men who have sex with men, the population of female commercial sex workers. Someone who has vaginal or anal intercourse without condoms with more than one partner. Someone who has a partner or more than one partner who has risk factors for HIV. Someone who has a history of STIs, either by self-reporting, either by syndromic, using a syndromic approach, or either by lab testing. And anyone with the use of post-exposure prophylaxis, this means that that person had been exposed to HIV before and had to use post-exposure prophylaxis. And of course, you're eligible if you're requesting. And so PrEP is not an approach where you say to the person, you have to be on PrEP, and so it's voluntary. What's important about all of the different studies and the results that we've seen, and we can go back, but what's important is that this can only work, PrEP can only work if there is good adherence. If there isn't adherence, PrEP will not work and transmission will occur. And so if you take, for example, the PROUD study, you had 100% adherence with the PROUD study. And the reason why there was 100% adherence with the PROUD study, it's because it was taken just before sex and it was taken right after sex. And so there was good adherence with that. And the efficacy of that is about 80%. But as you look at other studies where there's lower adherence, the efficacy is much less. There are a number of studies that have been done, and you can see this table here actually identify those. What it's important to note is that there have also been PrEP studies among women. I think we traditionally know that there have been a lot of PrEP studies among men, but there have been PrEP studies among women, but you can see that the efficacy really varies. And again, this is really highly dependent upon how adherent is the person in taking the antiretroviral therapy. The next intervention that I want to speak about is pre-exposure prophylaxis. Post-exposure prophylaxis, sorry. And this is for somebody, this is generally offered to somebody who is uninfected but has been exposed to HIV. It can be post-coital, it can be someone who's been exposed because of occupational exposure. So if you take, for example, a physician who got stuck with a needle, that's a post-exposure prophylaxis, but an occupational post-exposure prophylaxis. Someone who is working in a hospital that does health waste management, the people who collect their health waste, can be exposed, and then that would require post-exposure prophylaxis. So here is the risk for post-exposure prophylaxis. If you have a deep injury, your risk is about 15. And so you can see whether it's a deep injury, whether there was a visibly bloody device that was engaged, it's about 6.2. If the device was in the artery or the vein, it was about 4.3. So there are different risks in terms of HIV transmission and the need to offer post-exposure prophylaxis. What's important is that post-exposure prophylaxis is really time-bound. So if there is an exposure, post-exposure prophylaxis has to begin almost immediately. And in fact, after 72 hours, it's not effective. And so if there's an injury, if there's an exposure, treatment has to begin almost immediately. After 72 hours, it has. The next one is voluntary male circumcision. And the question was last presentation as to how this really works. And so there is some biological plausibility that I want to mention. Firstly, that the inner surface of the foreskin is highly vulnerable to HIV infection. And so once a circumcision is done, what it does is it reduces the size of the inner foreskin, and so there's less surface area within which the HIV virus can interact. It is up to 9 times more vulnerable than the cervical tissue, and even though there's more surface area within the cervical tissue, the vulnerability of the foreskin is much higher than that of the cervical tissue. There were a number of studies that were done that shows that in cases where there is a lack of male circumcision, that there is higher risk for HIV transmission. And in fact, there were 3 in Kenya, Uganda, and South Africa, and what it showed is that voluntary male circumcision offers 60% protection, so it was significant in terms of HIV prevention. What Kenya did, and some of those trials, Kenya, Uganda, and South Africa, again, they looked to see the durability of this kind of response, and so they followed up their patients 4 to 5 years later, and what they found was that the protective effect that voluntary male circumcision had on patients, that was sustained, and in fact there wasn't any transmission among that 60%. In South Africa, they did a community level impact intervention, and what they found is that voluntary male circumcision reduces incidence by 76%. So there's a real significant role in terms of voluntary male circumcision and HIV prevention. So this is one of PEPFAR's slides that they've used in Africa. And so what they looked at is their voluntary male circumcision program, and in the different countries, what percentage of infections they've averted because of their voluntary male circumcision program. And so if you look at Botswana, for example, you can see that between 2011 and what's projected to 2025, that they anticipate that with their voluntary male circumcision program, they will avert 28.1% new infections. And you can see the numbers. Zimbabwe, it's 41.7% and so forth.
If I may ask, but so the circumcision took place, but these figures, they reflect, or did they also track down these men then, if they went with women or men who were HIV positive? Because only then can you say that 60% were protected. If you do not track down that, okay, you've been circumcised, right?
But did you come into contact with
Yes,
persons with HIV?
that you have sex with HIV infected women and men. Was that done?
So the voluntary male circumcision program is a program. So it comes with the male circumcision, but it also comes with counseling, access to condoms, and all of the prevention packages. But it also would measure some of the behavioral kinds of things. So what's your sexual practices right now? Do you have X number of partners? How many sexual acts per week? How many sexual acts per month? And so forth. And I'm sure that that analysis is available, and I'm sure that it was measured as part of the program. Yes. Yeah. And I have no doubt that some of those questions that you're asking, the answer is yes. That they would have continued to have unprotected sex, multiple partners, the same kind of risk behaviors that you would see in the uncircumcised population. Yeah.
For us to try and locate some of those studies. Yeah.
And in fact, one of the things with PrEP that I didn't speak about is that the question is always asked, if you know that you're about to have unprotected sex, unprotected high-risk anal sex, and you're asking for PrEP on demand, that how do I know that you're not going to be doing this 2 times a month, or 3 times a month, or 4 times a month? But because it is a program, it comes with access to condoms, it comes with counseling, it comes with all of the support system that in fact, persons who access pre-exposure prophylaxis, that their behavior profile is much better than persons who don't access pre-exposure prophylaxis. So that's sort of a little similar to what you just asked.
So it's really combination.
It's combination prevention, right? What the projections and the analysis that's done, it tries to really pull out what's the impact of this specific intervention. And in this case, the specific intervention is voluntary male circumcision. And so these are really estimates in terms of averting new infections, so between 2011 and 2025. And finally, the other piece of prevention that I wanted to talk about is condoms. So condoms has always been around, and I know that a lot of programs are saying that we're shifting from talking about condoms and we're beginning to talk about treatol and we're beginning to talk about pre-exposure prophylaxis, but we're not to forget that there is the traditional condom that's available to us. And so what UNAIDS did in 2016 is they projected that if we're scale up our condom use versus not to scale up condom use, what would the picture look like? And so if you're to scale up condom use, this would be the number of infection that's averted. So a number of new infections will be on the decline. If you don't, and you maintain condom use as it is, new HIV infections will continue to rise, but you have an opportunity here to have this great impact if you scale up condom use. And so again, we can talk about PrEP, we can talk about treatol, but let's not forget that there's condom, which is a really important mechanism in terms of prevention. Here is how it looked, and I put a slide up because this is one of the few slides that we have Caribbean information. Haiti, you can see that the number of new infections averted in Haiti because of condom use. And again, there's going to be all of those other factors that are associated, but you can see that they have scaled up, and you can see the number of new infections. So Haiti is saying that at the end of 2015, simply by scaling up their condom program, that they have averted about 45% of new infections in Haiti in 2015. And maybe if we look at the Caribbean data much closer, and Dr. Green presented some of those at his presentation, Haiti is one of the few countries in the region that has really shown a reduction in new infections. And whether or not the scale up of condom use is one of the main contributing factors to that, I think we can take a closer look at that. So where does this all takes us in terms of what we have available to us? So we have PrEP, we have PEP, we have treatol, we have condoms, we have voluntary male circumcision, and the entire discussion of ending AIDS. So we know that if we look at the 90 that the Caribbean has signed on to, with 90%, the first 90 being 90% of people living with HIV in the region knowing their HIV status, it means that they have to be tested. We can see that in Latin America and the Caribbean, we're at 75% at the end of 2016. Of that 75%, or of that 90%, we should have 90% of persons on treatment, and that really works out to be about 81% of persons should be on treatment. In Latin America and the Caribbean, we're at about 55% at the end of 2016. And in terms of 90% of persons being virally suppressed, it's 90% of this 81% that's on treatment. Currently, we're at 41% of those persons that are virally suppressed. We've seen from the earlier trials that once you're on treatment and you become virally suppressed, then your risk for transmitting the HIV virus significantly dips. And that's why this 90% is really important, and it goes back to the whole concept of treatol and how can we use treatment to prevent new infections. This here is a picture of what exists right now at the end of 2016 for Latin America and the Caribbean. What it looks like for us is that for HIV testing, in some places we have higher coverage of HIV testing. So you can see, for example, that in Haiti there's 70%, in Jamaica there's 85%. So I think as a region we're doing good in terms of coverage for HIV testing. But when it comes to HIV treatment, and we just spoke about treatol and the importance in averting new infection and reducing death, reducing morbidity, we can see that as a region we're less than 50%, and this is at the end of 2015. We're less than 50% of having people on treatment. You have some countries that are doing well. Cuba, it's close to 70%. You have Jamaica, that's a little bit about 30%. And so if we're to avert infections, have less deaths, have less morbidity that's associated with HIV, we need to really be able to scale up putting people on treatment. So what's the future for prevention in HIV? There are a number of things that are upcoming. So you have, for example, vaginal rings, that's on the trial right now. You have vaginal rings that will comprise of antiretroviral therapy, and this can be used particularly among the female commercial sex worker population in terms of preventing new infections. These are on the trial. You have vaccine, there's several vaccines trial, but you have one particular vaccine trial that has entered its third phase, and so that's good. That's ongoing. And then there are trials that are going on with implants where you can actually implant slow releases of antiretroviral to prevent HIV infection. So just to wrap up, I think in terms of ending AIDS, we have quite a lot of good resources. We have good interventions to work with. We have treat all, we have PrEP, we have post-exposure prophylaxis, let's not forget condoms, and there's voluntary male circumcision. This here is a patient who is from Haiti. He has TB HIV, and this is it in the really very early stages of the epidemic. This is actually one of Dr. Jean Pop's patients. But once he was placed on treatment, this is what the same patient looks like. And so you can almost see that there is going to be one reduction in morbidity, so less illnesses. He will probably be living a longer life. He's probably still alive, I'm not sure. But this is what treatment can do to you. And in addition to this, remember that if you're virally suppressed, then the risk of transmitting the HIV virus is significantly reduced, and that's the treat all concept in terms of treatment as prevention and averting new infections. So what will it take to end AIDS? And according to Dr. Anthony Fauci, who is the director of the National Institute of Allergy and Infectious Diseases in the US, he says that there is absolutely no scientific reason at all why we cannot end the epidemic, and we've just seen some of the science. HIV is not going to outflank the science. If anything at all, if HIV outflanks anything, it will be our inability, to properly manage our response. And according to Ambassador Burks, she said that a community issue is whether all clients feel like they can access treatment, whether they want to know their status, or whether there is so much stigma and discrimination at the community level that they feel they can't access and know their status. And so my message is that the science is very clear. I think a lot depends on our own actions, how we implement our programs, how we discriminate or stigmatize, or we don't discriminate and don't stigmatize. And so I think it's some of more of those community issues, some of the implementation issues, some of the policy issues, some of the structural and enabling environment issues that we need to take into consideration to really add to the science to bring an end to AIDS. I want to take the opportunity to thank Professor Clive Landis, Dr. Anton Bess, and Professor Peter Figueroa. I've used some of their slides in my presentation, but the majority of my slides were actually taken from clinical care options, primarily from two of their conferences, the CROI 2015 and 2014, and the International AIDS Society 2016. Thank you.
Thank you.
Thank you very much. So you see, if you would not have been here, what you would have missed, right? And I will tell you very honestly, I was not aware that HIV/AIDS causes cancer. I thought cancer is one thing, HIV/AIDS, these are several things. So okay, and I learned something today. So it can be one of the causes. So one more reason why we have to know our status and our status. And that's why I was asking the question about the CD4 level, if it's now below 350 and so on. And I know for cancer they also have, I'm not a I'm not in the medical profession at all, but they're also looking at some level, whatever thing, if it's below or above, and so you're more susceptible to developing the cancer and those types of things. So, okay, some things are coming clear to my mind, but I do have 2 questions, but I would like to give the floor to, please, you have the floor to ask questions, ladies and gentlemen. That's why you're here. Ms. Bishop?
I have a question.
No, I don't insist. I know you want to ask a question or you have a comment.
No, my comment was actually based on the last slide with the guy before and after, because I think in the early stages of the HIV prevention, we normally would have seen persons who suffer from malnutrition as the picture of a person that's HIV positive, which really and truly is not the case. And you look at him now. So any of us can be the face of HIV.
Exactly.
Or even a person who's diabetic, eh?
Yeah.
They also, but it's not diabetic, so that's why people say one has a headache and another one has a headache doesn't mean that the same sources causing the headache, the things are the same or the same medicine is needed for both, which I always keep saying, people who have in our organization high blood pressure and so on and so forth. Anyway, other questions, comments? Gentlemen?
I want to ask a couple of things.
Yes, please. Yes.
I'm asking on his behalf. He asked what's the cutoff age for circumcision. Self-circumcision or voluntary
Why? I don't understand why people are laughing. Because I had a question in relation to circumcision also, because I know in certain traditions and groups, you start as a baby, right? After the baby is born and after so many days, and it's a festive thing, you know. I know people. I'm from Suriname, so I know the people from Indonesia, for example. They have a big celebration, and you're invited. It's food and everything, you know. And I know also the Muslim population, those coming from India, they have also, and then you have the Jews also. It's a big thing. It's nothing secret, you know. So in the Western world, we do like it's something out of the order, but in Suriname, it's something normal, right? And of course, you have certain groups who don't do it. And then you have men who have to do it due to medical reasons later on. So, and cutoff age, look, I don't want to talk too much, and some people might not like it when I say it, but you were here when we had last year the gender, yes, and the issue came up about the Caribbean men, right? So I don't want to go into it, but maybe it would be good to hear from Mr. Springer. What's the cutoff age? Because you men said it yourself. There is a Caribbean culture, right? Isn't it? It was mentioned. Who was there in September last year? Yes? No, but I'm sure some men were there because they had to answer some questions, right? So, given that culture, and it's not, I don't mean it negative and so on, I cannot answer that question. So, Mr. Springer, maybe you can answer that question, or Dr. Singh? Yes, Mr. James?
How prevalent is male circumcision being promoted as a means of prevention in the Caribbean? And it's the first time that I'm hearing of it as a means to prevent AIDS in the Caribbean. Are we actively promoting it in the region? Because it's the first time I'm hearing in a forum like this. So are we actively promoting it?
Don't you want to answer that question? The promotion piece?
Okay. In terms of the promotion, as I'm hearing my colleagues here saying, this is the first time they're hearing about it. But in fact, it is something that has been on the agenda. The issue is that at the level of the countries has to be the policies that countries determine to pursue. And of course, cost is always associated with any decisions that you make. However, I don't think that we have promoted it as aggressively as we should. And given the National AIDS Program Managers and Key Partners meeting that we had in March, in which all of these options were brought back on the table, it is something that PANCAP will be seeking to actively promote in the region as we address the whole issue of combination prevention.
Talking about cost,
Okay.
what? Yeah, have you thought about it if the region goes that route?
Yeah, and of course, as with anything else, one of the things that we do at the regional level is to support with assistance from our partners these economic analysis, the financial analysis, because of course governments will need to know how much it will cost them if they have to implement a particular program. It is the same issue that we are dealing with now, that we are moving from the threshold of 500 CD4 for treatment now to treat all. And so countries are asking us what will it cost them to move to treat all. And as such, with support from PAHO, UNAIDS, and PEPFAR, work is being done to conduct a number of analyses to help countries to have a sense of how much it will cost them. What we are promoting is the issue of an investment in the HIV response, and therefore if you invest upfront, while it may cost you significantly, at the end of the day it will cost you less in the years to come, particularly in relation to ensuring that people are living longer, people have a better quality of life. It means that there will be less opportunistic infections, they will have less hospitalization, etc. And more importantly, people will be able to have productive lives. We have looked at the Barbados experience of moving to treat all. And Dr. Singh had that responsibility through the Knowledge for Health project for going to Barbados and documenting the process that they initiated to first develop a treat all policy, which was then approved, and they were able to get the support of the government to move forward to roll out that policy of treat all. And so that is going to be shared as a regional public good to other countries, so that they have a sense of what it is that needs to be done in order to move to treat all. Additionally, I think it's important that we recognize that as we speak about where we are in relation to the 1990 targets, in terms of where we are in relation to the testing and then keeping people on treatment and helping people to become virally suppressed, that previously, that is before WHO introduced the 2015 and then 2016 guidelines in relation to treat all, the region had much more eligible persons who were HIV positive and that were eligible for treatment on treatment because of the threshold that was being used. But once the decision was moved to treat all, it means that you cannot put everyone on treatment overnight. It's a process, and as such, that percentage, that proportion would have dropped. It is also necessary for us to be able to inform the public and to get buy-in, because many people are of the view, and this is based upon what they had seen and heard, that people were only treated when they got sick or when their CD4 fell to a certain level. And now we are saying that you need to go on treatment now, as soon as you find out that you're HIV positive. And of course, people are concerned that they have to remain on treatment for the rest of their lives. So it requires public education, but it also requires the one-on-one interaction between physicians, between counselors, nurses, etc., and persons who are living with HIV, so that we have a paradigm shift in the way people think as it relates to treatment. So PANCAP is also supporting that effort at the regional level in terms of working with national AIDS program managers, civil society organizations, and then through social media to be able to inform the public. But we also have to be aware that it's not something that we can rush to, because we must make sure that countries are ready to move to treat all. If not, you have a situation where as persons test positive, people are demanding to be placed on treatment immediately. So we have to ensure that we support countries in their efforts to be able to move towards treat all. The other thing to mention is that as we look at treat all, we also have to look at how do we ensure that there are efficiencies as a means of ensuring that governments can manage to support the treat all program. And so at the moment as we speak, our partners are supporting countries to be able to look at an assessment of the supply chain management, in recognition that it is not just a focus on the procurement of the medicines itself, but also we have to take into consideration things like forecasting, storage, etc. So we don't have a situation where we are purchasing drugs that have a short expiry date, and then you end up with millions of dollars of drugs expired and then cannot be used. We also have to ensure that we look at the whole issue of pool procurement. Now, the OECS is an excellent example of pool procurement, where those countries have been able to look at how they can pool in terms of the amount of antiretrovirals that they need and to be able to source those. And in doing so, it means that they have cheaper prices. The challenge that we have seen with some of the other countries is that they have not been able to do so. We have some countries, for example, who are still using the patent drugs, which are much more expensive, and so they need to move more to the generic drugs, which are cheaper, and to use mechanisms such as the PAHO Strategic Fund, which will not just assist in terms of the lowering of costs, but it will also assist countries to address issues of indicates that they're likely to stock out within a week. It means that truly, if you have countries using the we have to look at how best we can ensure that the prices that we are paying are and lastly, in terms of the PEP that Dr. Singh spoke about, which is the post-exposure prophylaxis, it is also used in cases where you have rape, so that if a person has been raped, and they report that individual should be eligible for post-exposure prophylaxis. Thank you.
Thank you, Dr. Springer. But the question about the max age for circumcision, Dr. Singh?
Yeah, thank you, Estelle, for asking the question on behalf of your colleague. I don't know if there is a maximum age, but what I would say, if you're sexually active, it has the benefit of having male circumcision. If the person is not sexually active, a very older person, then that's fine. But I think the other spin-off benefit of male circumcision is that it really is a good hygiene practice. And so I would recommend male circumcision anyways. Yeah.
Yes, Dr. Yeawood.
I have to thank you, very enlightening and educational for me. But my question has gone through my mind, probably the topic of another discussion, the social responsibility. I saw a picture, as my colleague raised, of a very healthy looking individual. Now, I don't think anyone walks around with a saying that I am HIV nearly cured or treat all or so on. How is that now being communicated? Because, you know, that picture is an eye-opener.
So they look healthy.
Yes, they look healthy, but they're not going to report and say, oh, by the way, I am on viral 4, 5, 6. I'm on Tritol. I don't think we walk around with a tag of that nature. How is that? And in the context of, I guess the governments are giving these medication out. What is the social responsibility? Is it the individual? Is it the government to have a register? I don't know. I'm just, my mind is just reeling, and I'm reeling in the context that I am, very concerned about the youth. Because, as I said, that picture, if I had a daughter, it would be a nice young guy for my daughter. And, he's on viral 4, 5, 6.
Even a son, these days.
But, I just need to hear on that. And, of course, it might be the discussion of session 2, which I will attend.
You mean session 3? And if I may add to it, please, the picture I saw there, again, and I say this from the very start, prevention, I think, is important. To what extent are you also focusing on giving the people a voice in informing others, informing us what they have to go through from that stage, looking healthy and wealthy as in the other, because I'm sure there is a process that you have to go through, which then comes to the question about social responsibility. But I would like to go beyond that, and that is about behavior, your individual responsibility, and the attitude. I think it comes along with that, right? Because I just want to give an example. Quite a few years ago, when I was ambassador, there was a case in one of the islands whereby a young lady was going to be married to this gentleman who was coming from St. Lucia, and the medical profession person knew that he was HIV positive, and his family knew through that because they were linked, but the girl did not know. And when we heard that the issue was, how do you inform, because it's one big thing, trouble and fights and do those types of